Good morning, everyone. So my name is Sisi. I am a fellow at Harvard Law School where I focus my academic research on the sole issue of clinician well-being now. I am also a co-founder of Atalan, where we do translate a lot of the science that we do into a decision-making tool designed to help healthcare leaders across the country to address the issues of clinician well-being. So surveys are really good, and they're really important to start getting data and information on the clinicians that you're trying to support as healthcare leaders. However, nothing is perfect in this world, as we all know, so surveys have their limitations. So one of the key limitations that I'd like to draw attention to as healthcare leaders is that surveys are subject to something that is called non-response bias. So what is non-response bias? It's basically, you've got two groups of people, right? You've got the respondents, and then you've got the non-respondents. So for whatever reason it is, these two groups of people are systematically, fundamentally different from each other. What does that mean for you all healthcare leaders? It means that whatever data you get on the respondents cannot be generalized or cannot be translated or transferred onto the non-respondents. So of course, as scientists, we were curious, right? This is, what evidence do we have to support this theory? So we did a study with a nationwide health system to look for evidence for this. So first of all, does non-response bias exist in the well-being space, in the well-being survey that they did? And secondly, if that is the case, what could healthcare leaders do? We found two really key insights. So what we basically did was compare the respondents and non-respondents, right? Looking at their differences. And we did not focus just on the demographic differences, which is what the literature tends to focus on. We actually focus on the work behavior. And we focused on two metrics that I know you all care about. One is turnover, massive deal for patients, for our patients and for our physician well-being. And secondly, productivity, which is very important for revenue and for patient experience too. So what we defined is, first of all, we found that non-respondents are between 3 to 9 times more likely to leave. Now, we were not super surprised by the non-response bias, but the magnitude was very surprising for us. So they're 3 to 9 times more likely to leave. And most importantly, throughout time of the period that we looked at, which was a 2-year period of the study, they are actually between 15 to 30% less productive consistently throughout time. And these are all statistically significant results. So what does that mean for you all healthcare leaders? It means that we need to somehow figure out a way to capture the voices of the non-respondents, the very people that you're trying to find but you have no data for. So how do we actually do that? So this really cool stuff we've been working with Tim on, such an honor, is to try out a new way of looking at this, to really capture the voices of non-respondents. We do that by leveraging data that you already have. It's already in your data warehouses, and it's the leveraging EHR and HR data. So how does it actually work? Because our EHR and HR data covers everybody, you're actually able to get data for everyone, not just the respondents. The way that it works is we basically get all the data, right, of EHR and HR data. That covers everyone. And then we leverage machine learning. We can leverage machine learning and AI to actually tidy up and sift through hundreds of variables in the EHR and HR data to actually make some predictions, to make predictions on everyone who, basically as a probability of leaving. So what is the likelihood of any individual going to leave up to 12 months ahead of time? This is a validated model that we have tested across multiple health systems in the country. So you can see, okay, out of all of the population that you're trying to help, they might be struggling. So you're really catching the people who are silent sufferers, which is what we hear a lot from our health system partners, is one of the key things that they found useful. Now, you've got the voices or the potential voices of the people who are silent sufferers. What next? You can also use leverage machine learning to actually figure out what are some of the issues that they might be struggling with by looking at all of the proxies and the data within the EHR intra-systems. These are things like time spent on notes, or patient volume, patient complexity, schedules. So we have computed 100+ work determinants of well-being, which are drawn from scientific literature. So we've read thousands of academic papers, which basically says, at some point in time, a particular health system has found this particular work determinant to be predictive of turnover and burnout. So we basically gather all of these hypotheses-driven data, put it into the machine learning model, and then it generates insights for everyone. So it highlights the top issues that they might be struggling with, and you might want to help them with. The third step is we go one step beyond. So you all have patients, and you all have things like BMI or healthy ranges for your patients, right? It turns out that all of these work determinants, they have their healthy ranges too. So what we have been able to do is to empirically derive some of the healthy ranges. So for example, time spent on notes. You cannot tell your clinicians to stop seeing your patients and stop documenting. But what is that range of healthy range of work, time spent on notes that you can, that are correlated with the lowest turnover risk and lowest burnout risk? And we analyzed thousands of clinicians across the country to get those healthy ranges. So with all the data and AI, you can actually do a lot of insights and digging. But you are the leaders. You are in control of developing programs for the well-being of your physicians, nurses, and clinicians. So you decide, okay, well, now I'm going to launch some in well-being programs, but based on hard evidence, I know for sure that these people are struggling with time spent on notes, or these people are seeing too many complex patients. So then you basically develop, you decide to launch a well-being program, let's say a scribe program, to address the time spent on notes issue. Then you can go back to actually the data. Because we track these data on a monthly, regular basis, we've actually developed a whole platform to do that in real time. So basically, at any point in time, once you've launched your intervention, you can actually start tracking, is whatever I'm doing actually working or not? And you can tell by looking at, did it change their productivity? Did it actually reduce the time spent on notes? Did it actually improve other outcomes that you care about? So that's the final step where, because I've heard a lot of, we've interviewed 114 health systems across the country. Everybody talks about silos. So data has its own silos too. So this actually, a new way of doing it is that you can actually connect the data together. You can look at the data and look at how all these work determinants of well-being are connected to quality metrics, which ones actually drive higher patient experience, which ones drive better outcomes that you care about.